it has become very, very important. You can see an example where you have good fixation, you have repeatable measurements, you're able to image the fovea, and the patient has very similar repeatable IOL power calculation. Whereas in patients where the fixation is not good and the foveal pit has not been imaged, it's a very, very small difference in the axial length, 190 microns, but that makes more than a diopter of difference when it comes to the IOL power calculation. So it's really important we ensure this, and the foveal pit is accurately imaged. You can also, it alters your workflow. If you detect any basic macular pathologies, that can also be detected. Can I take a minute longer, sir? Yeah. So the last aspect of the talk which I'd like to talk about is combining biometry with topography, which now a lot of devices are able to do. You have traditional biometry devices like the LensStar, IOLMaster 700, Aladdin, which are essentially biometers but are now combining a Placido image with the biometer. Or you have topographers like the Galilei G6 or the Pentacam, which were originally tomographers but are now giving a component of axial length. Now, suffice to say that they are giving repeatable and comparable results. While the Placido images with the biometers are okay for astigmatism, they are not really useful as far as keratoconus or other imaging is concerned. It is more for your toric IOL and other calculations, but the accuracy, the results are comparable between both the devices. Just a quick example of an image on the TopCon, which is giving you a lot of data from the Placido disc. You get keratoconus screening, you get the Zernike values, you get pupillary data. Also, in one single shot, you are actually able to analyze all the parameters of the patient. This is from the LensStar, and with the TK, because the TK values are visible, the toric IOL selection is visible, the whole method of counseling, talking to patients, everything becomes a lot more easy. Although, like I said, these images are definitely not transformable to what you get in the tomographers, but are accurate enough for the K values which we require. So to conclude, we have excellent imaging systems nowadays, and with the 5th generation IOL power formulae, emmetropia for everyone, as Sir said at the beginning of the session, is a real possibility nowadays. Thank you so much for your kind attention.
Thank you, Dr. Shreyas, and I think he has to go to another course, so if there are any questions regarding biometry, you can just, go ahead.
Optical, that's what I wanted to say this, and I could have put innumerable other papers which compare one device with the other device. Optical biometers are definitely the way to go. There is a certain accuracy which does improve. Whichever optical biometer you're able to get hold of among the standard companies which we've discussed and I put up in the slide, they are all having excellent agreement, excellent repeatability, and you will do well to purchase any one of them. I have no financial interest in any one of them, but definitely you can buy any one of those equipment.
You'll also have to look at your other equipment. Suppose you have a Zeiss microscope like the RTO800 or the Lumera 700 with the Callisto system, then it makes sense to go in for a Zeiss IOLMaster 500 or 700 because they are linked and your workflow is much easier. So these are all things that you need to take into consideration. Of course, like Shreyas said, telecentric keratometry makes it much easier. If your optometrist doing it, an inexperienced person doing biometry, it's a little more forgiving. And you also have the foveal pit, which you can see whether you're on the visual axis while measuring the axial length. So these are all small things which kind of matter, but you'll have to look at the features and the price and the other equipment that you are having and finally take a decision. You also have other equipment like the Pentacam Wave AXL, Pentacam, which also gives you the axial length and other measurements. You have the Anterion. There are quite a few devices which are there now, but you'll have to kind of look at what suits your practice and what are your needs, what kind of work you're doing, how much of premium IOLs are you implanting, and then decide on it.
And wonderful equipment like Anterion, other even MS39, OCT based tomographers, that's really a talk in itself, which is really improving the accuracy and the detailing which we are able to get of individual components of the cornea, anterior segment and lens. It's definitely a game changer.
Thank you, Shreyas.
Thank you, sir. Thank you so much.
We'll go on to the next speaker, who is my dear friend, Dr. Gaurav Luthra from Dehradun. He is a prolific cataract and refractive surgeon, and he was also associated with evaluating the Hill RBF formula, and he has a lot of experience in refractive cataract surgery, and it is my pleasure to invite him to give his talk on different IOL formulas, what to choose when, for what type of a case. So over to you, Dr. Gaurav.
Hello. Yeah. Thank you so much, Ganesh, for inviting me to this amazing course, and it's always a privilege to be there, and very good afternoon, everyone. And going ahead with the topic, which is actually a huge one. We've come a long way, and starting from the first generation formulas, which some of us had the privilege of using, and then going on to the second generation formulas, the Holiday and the SRKs, which we probably used in our college times, and then of course going along to the SRKTs and the Holiday ones, which became popular, and then the fourth generation. So there's been a huge evolution, and today we are at a benchmark situation where we can actually say with almost great certainty that 90% of our patients will be plus minus half diopters of what we are aiming for, and these are the formulas on the right, extreme right, which have allowed us to reach that level of accuracy, of course, with the help of optical biometry, because measurements were the benchmark, were the cornerstone of all these formulas. So as you can see here now, when we started off, we used to have formulas which would either be, like the Hoffer Q, which was great for short eyes, and then for the long eyes with the Wong-Kok adjustment, we could use the SRKT. So they all had their own plus and minus points. But today, if we look at the bottom of this table, the Barrett's 2 and the Hill RBF, they seem to have the best range for the short as well as the very long eyes, and both of them do extremely well. So these are the two formulas which, if you are looking for just a one size fits all for 90%, 95% of your patients, these would be the two formulas, which with the new version of the Hill RBF as well, which can go up to the minus meniscus lenses as well. Both of them are extremely good. So starting from the SRKT, which is a theoretical formula and which we have been using for long, it still holds true, because when I have to do a manual biometry in the mature cataracts, I would still go back to the SRKT. So SRKT strengths are basically for long eyes as well, and using the Wong-Kok adjustment as well, it can become a very useful formula, and should be preferred for not only the standard eyes but also for the longer eyes, especially if you are doing an ultrasonic biometry. However, the SRK 1 and 2 should no longer be used because they are obsolete and they no longer are justifiable. The Hoffer Q has been a favorite for pediatric cataract surgeons and for short eyes because it relies on a personalized A constant, and also for the axial length and the corneal curvatures. And it was and is the preferred formula. Even today, while we might measure the short eyes with the Barrett's and the Hill RBF, we don't miss out on the Hoffer Q as well, because it adds a lot to the information and can be a very useful formula for the very short eyes as well. The Holiday 2 and the Holiday IOL Consultant, which were very popular, and still Holiday 2 remains on some of the machines as a very popular formula, is again a very versatile formula from the short to the long eyes. And again, the Wong-Kok adjustment has been shown to extend the usage from the short normal eyes to the short long eyes for the minus lenses as well, and can be still used, but nobody knows about how it works. The Jack Holiday has kept it confidential, just like the Barrett's formula. Nobody knows the algorithm that is used. The Olsen C came in with a lot of promise. It's a ray tracing formula and uses the C constant. I don't use it personally. It has been popular with some surgeons. I tried to use it a few years back, wasn't so satisfied, but it is still one of the popular formulas. And I did work with Warren Hill in validating the Hill RBF from the Indian data point, and it does not depend on the ELP, so that's the advantage, and it's an artificial intelligence formula. The 2018 update and now the recent update to the Hill RBF 3 has made it a dramatically better range, because now you have the short and the long eyes from the 40 diopters to the -5, and the whole database has been increased, so the predictability has increased drastically, especially in the shorter axial lens. So now you will see much more versatility of the Hill RBF for short eyes. And now you see very few out-of-bound eyes, basically eyes where the artificial intelligence will not be able to predict it correctly. And you can also now aim for residual errors, which was not possible before. Previously, you could only aim for emetropia. Now you can actually set, for example, if you are aiming for a -0.25 or a -0.5 or something else, you can actually feed it into the formula and it will work. And it does come with its own toric calculator, which is almost similar to the Barrett, so there's hardly anything to choose between the two toric calculators. Now coming to something which most of us tend to use today, 90% of us might be with this, especially for us who are doing optical biometry, because the Barrett suite has takes into account the posterior surface of the cornea, which is included either by measuring it or by using the nomogram for the posterior case derived from the anterior case. So Barrett's Universal 2 for all non-toric IOLs is the benchmark. And then the Barrett's toric calculator, which is really popular, and I use that for all my toric lenses. And the Barrett's True-K for all the non-toric, especially in post-refractive surgery patients, is again my go-to formula for post-refractive surgery. Dr. Sheetal will be talking on that soon. So here the important thing is that for the posterior surface in the Barrett's suite, when you're not using the Barrett total K, or the Barrett's TK, which Shreyas was talking about, you are not using the measured posterior surface, but a nomogram, which is proprietary and has been very useful for 90% of the cases. So the Barrett's Universal 2 being a Vergence-based formula, and it does use a lens factor and a design factor. So let's see how it works. It works for all types of eyes, from the short to the normal or the long, and that's why I said it's one of the go-to formulas if you want peace of mind of using one formula for most of your surgeries. So what's necessary is the axial length and the keratometry and the lens factor, which is derived from the SRKT, and the optional factors are the AC depth and the wide to wide, the lens thickness, and the design factor. Now design factor is again, let's see how it is derived. So the lens factor is basically calculated out of the SRKT constants, and the design factor is IOL specific. So it also influences the IOL calculation. So you could actually do a calculation without the design factor, but it won't be as accurate. So to add accuracy to it, and that's why it becomes important to be measuring all those optional things which I was showing you on the right column, if you want to really make the Barrett suite work for you really well and get you more accuracy than you might get with just the axial length and the corneal measurements. So without the wide to wide, the AC depth and the lens thickness calculation, as I said, it's possible to calculate, but it won't be as precise. So the whole advantage of using the Barretts would be lost. Now the toric calculator, again, when it came out, it was amazing, and we suddenly all our concepts were changed when Barrett's toric calculator came out and was integrated into many of the machines, because it incorporates a mathematical model to calculate the posterior corneal astigmatism based on the anterior keratometry measurements. And of course, with the new IOLMaster 700, you can measure the total K as well, where you can measure the posterior cornea in post-refractive surgery. I'll just come to that. So the Barrett's True-K, which we use for post-refractive surgery, I think Sheetal will be talking on it, so I'll probably bypass this, and she'll probably be talking on the ASCRS calculator as well, so I will allow her to speak. All I would like to say is that when I do my post-refractive surgery patients, I like to add as much data on the ASCRS calculator as I can. I try to put in the pentacam values, I try to put in the topography values from the optical biometer and from the OCT. Now what that does is that when you have all that data fed in, after choosing what kind of eye you're operating on, you will get predictions on, using no prior data, and if you have some prior data, then you will get it on this side as well. So frankly, you will get several of these measurements, and then I tend to usually choose the one which goes to the higher side. Of course, you have to kind of sometimes see the pentacam can sometimes be horribly wrong, but sometimes it really works well, especially in RKIs, where I use the pentacam measurements for the EK65. So this is how the pentacam holiday EKR report looks. So this has been really useful for some eyes where the keratometries are below 30, very flat corneas which cannot be measured by most of the optical biometers, and there you can use the EKR65 values starting from the 1 millimeter zone going out to the 4.5 for predictability of astigmatism if you want to do toric calculations, and for the keratometries, and this works very well for those eyes which cannot be measured by almost any device. So this is something which I really trust now. And of course, now coming to the total K, I think Shreyas spoke on this, but it is integrated into the IOLMaster 700, and I will, it can be used mostly for post-refractive surgery eyes. There has been mixed opinion about how good it is. Some people find it amazingly useful, and others feel that, it doesn't add so much to the values, but maybe we can have that more in the discussion, Ganesh, on this. You have more experience. I don't use it, so yeah. And going on to the ultrasonic biometry, as I said, you have to, of course, have the A constant, and I use the SRKT there. And immersion is obviously necessary when you have opaque cataracts. 90% or more can be measured now with the swept source OCTs. So very few patients where you will not get a measurement even with very opaque cataracts. But when you just cannot, then you have to go by your manuals. And then, of course, it's very important to compare this data with the fellow eye. I always like to compare my manual measurements for the fellow eye. If you have discrepancy between the two eyes, you can immediately be alerted, and you can kind of go back and look at it, and look at it again, especially with posterior staphylomas and all, where you might go wrong with these eyes. So I think most of us know about all the variables which are required for the various formulas. Some are optional, some are mandatory, and I think it won't make much because we are not using most of these formulas now. You're only using the two on the right. So I think these are the ones which currently matter, and most of them will use all these variables, and that's what makes these formulas more accurate. Now, some of the new formulas which can be used, the super LADAs, which has been again an artificial intelligence based formula, and can be used. It's available for free on, I think, iolcalc.com. And this was what is popularized by Uday Devgan. Then the Kane formula, which holds a lot of promise and compares really well in most of the new studies, and has been used, for good post-op outcomes. And then the EVO formula, which is out of Singapore, and again very promising as it appears. And then the ray tracing, which is now available on some of the new machines like the Antirion, and many machines now offer the option of taking their measurements and using ray tracing calculations for eyes, especially post-refractive surgery eyes, where it will be really useful. Can't go into the details of these formulas, these ray tracing formulas, but they can be used with the Oculix software, which is again available free of cost, and can be installed onto any PC once you enter all the data from one of the machines which can gather all that data for it. So a lot of applications, especially in post-refractive surgery, post-RK, where otherwise you may not be able to get great measurements. So these are all the devices which can be used for ray tracing calculations: the Pentacam, the Galili, the iTrace, the TOMI, the MS39. They can all be used for, all these data can be put into the Oculix and used for your calculations. So I think I still have a little bit of time, or have I exceeded it already? Yeah, I have. Right? So I'll just summarize. I think we spoke about the short eyes. We can use the Barrett's, the Hill RBF, and the Hoffer Q. For the long eyes, this is the comparison of all the formulas for the short eyes, the long eyes, where again now things have got better and we can actually get great outcomes with some of the newer formulas, the Barrett's basically, and the SRKT when required. And I'll just finish with the last 1 or 2 slides. So post-corneal transplantation is a full thing in itself. I would prefer to do a secondary implantation if you're looking for to avoid surprises. And keratoconic eyes, you have to be very prepared for hyperopic surprises because it wrongly estimates the ELP. So the go-to formulas would be the SRKT, the Haigis, or the Hoffer Q. So to summarize, the SRKT formula is recommended for the rather long eyes, whereas the Hoffer Q is recommended. This is what we've always done. And currently, I think the 4th generation formulas, which we just spoke about, the Hill RBF3, the Barrett's, Haigis, and the Holiday 2, should provide the highest accuracy. But you have to always look at them with a very keen eye, and then you won't make much mistakes. Thank you.
Thank you, Dr. Gaurav, for that excellent talk. If there are any questions, we can take them. Meanwhile, what is your choice of formula for post-RK eyes? Because this is something which I think a lot of us face difficulty, and we have refractive surprises. These patients also are demanding, they have undergone refractive surgery. So do you have any
I do a lot of post-RK eyes, and the biggest challenge is they're really flat. Sometimes, the keratometry is like 23, 24. Now my lens star doesn't measure flatter than 30, and if you try to use the T-cone, you again don't go beyond like 27 or 28. So what I now rely, because the problem lies with accurate K measurements rather than with the formulas which you might want to use. And then I use the Ascaris calculator fed in the OCT based data, the Pentacam based data. These are the two which will fit into it. Other things will not even go into the formula because it doesn't take lower than 30 Ks and all. So then we've kind of worked around a way and found that to work well for us in these post-RKIs, and then still err on the side of using the highest power lens available and then add another one to it. And then so you might just hit jackpot.
Have some amount of residual myopia.
Because absolutely. So that's what has worked. And I also have done quite a few torics now with our post-RKIs, which initially I used to totally avoid, but seems to be working really well again using the pentacam. If it has different optical zones are showing consistency in the axis and the magnitude of astigmatism, you can still go for it and looking at the maps and trying to pick up those cases where it will work. So it has been very gratifying for some of my patients.
What I like to do for post-RK in cases now is to use ray tracing.
Ray tracing,
because
yes.
that accurately measures all the optical elements, and then by ray tracing you're able to kind of
that's what I actually spoke about.
Still I kind of want to target about 1.5 diopters of myopia, and you end up with.
Are you using the Oculix and feeding data from few of these
CSO.
machines?
CSO
okay, on the
MS39.
CSO. Yes, that's MS39 is the one, is it?
Yeah, MS39.
That has the ray tracing built into it. It would be great to have it built into your device. Otherwise, kind of putting it into another system and gathering all the data is so tedious.
Thank you very much. Are there any questions for Dr. Gaurav on formulae? Otherwise, we'll go on to our next speaker. I have the pleasure to introduce Professor Jagat Ram. He was chief of PGI and has extensive experience and also with the latest devices, and he will be talking to us on Intraop Abberometry, the pros and cons, because I think there are very few centers in India having Intraop Abberometry. It is popular in the US, and you can kind of on table measure and remeasure to get more accurate IOL calculation, especially in challenging cases like post-refractive surgery, post-RK. So over to you, Dr. Jagat Ram.
First of all, I am thankful to Dr. Shri Ganesh for giving me this opportunity to speak on intraoperative abberometry, pro and cons. Please put on the slide. What is opti-wave refractive analysis or intraoperative abberometry? This is I think used for the last more than 7-8 years we are using, and it uses the infrared light and interferometry and almost 40 measurements in less than a minute. Analysis of the data is of the central 4 millimeter that calculate the IOL power. It is not, we don't do in every case. I will show some of the cases where we practically do it. There are some pros that this is found to be much better and much more accurate, particularly for IOL power calculations where there is a history of radial keratotomy, LASIK and PRK, particularly RK, radial keratotomy, among the refractive procedure. And another is placement of the toric IOL. We have also used it in adult and pediatric also, that what is the power of the IOL and where we align this IOL. And patients' expectations are very high, and they have particularly we can deepen or extend the LRI to avoid post-operative enhancement, and it is found to be much more accurate in myopes. Whereas there are some of the issues that it cannot be performed in patients where there is low IOP. So most of the time we have to inject viscoelastic substance, and intraocular pressure should not be low. If it is low, it will not give the reading. Extorsion in the spine position, this is another problem, and if there is central corneal opacity, it will not measure. Even in RK, if there is a central corneal opacity or there is a haze in the center, it will not measure the IOL power calculations. There are others, such as if there is a fixation problem in those patients with nystagmus or having age-related macular degeneration, it will not measure. I will like to show a few of the cases of where we have used it as such for toric as well as for multifocal IOL implantation. This is one such patient. Here this is a simple case where we will be using multifocal toric IOL implantation, and actually we were not sure that it was accurate or not. So initially what we did, that we compared it with our another regular biometry, and then we extended the use to the toric IOL implantation for its power calculation as well as alignment, that whether alignment is accurate or not. So this is one such patient, multifocal toric IOL. Here see this intraoperative abberometry, and then it will show, it has to be absolutely accurate, IOP and everything. It shows that okay, you have to use 21, or I think plus minus, that you have to do from your own side, that it should be first plus or it should be just closest to emetropia. Here that point of time this Symphony IOL was used, and this is a Symphony toric IOL. And after then we will see whether alignment is fine or not. So maybe in the next case. And this is another pediatric cataract where there is astigmatism, and we have used aura. So although we have marked as such also, and after doing continuous, after making the incision and doing continuous curvilinear capsulorhexis, removal of the cortex from the capsular bag, and then we have to fill the capsular bag and NDG chamber with viscoelastic to calculate the IOL power. So adequate IOP has to be there, and now it will calculate the IOL power. And then actually in children, if it is child is less than 6 years of age, or other infant in the first 2 years of life, we have to undercorrect. We have to undercorrect that what power we use. So it is not exactly the same power which comes out. So undercorrection is done particularly in children. So here it is the alignment which is shown by Callisto, and this is a toric IOL. And then it will again we will do that whether alignment is fine or not. So it shows no rotation required, means there is a astigmatism of 0.15. But we have compared it with the other routine method, and we could find that this was found to be significantly accurate. And this is another patient where phacoemulsification is done in eyes with radial keratotomy. So we did the planning, and because incision has to be made where there is a clear area, not along the radial keratotomy area. So here after making the side port incision, and after using the flax and we have to do selection of the side port and the main incision, where you want to make the side port, where you want to make the main incision, because otherwise many of the time these incision may open up. And then phacoemulsification, and This is one of the eye while we were doing trial of control control with the normal method. That point of time, this surgery was done about 4 or 5 years back. So adequate IOP, it should not be low IOP, and then it will calculate the IOL power, and it has shown that you have to use 31 diopter IOL, so you have to have inventory of IOL, but routinely in using the other formula, it may patient may become hypermetropic. There will be residual positive plus lens. So in other while not using this technique, you have to add some +1 or 1.5, but in this it was not added, and it was found to be significantly accurate. So in conclusion, intraoperative aberrometry is a newer technological advancement which can be used in patients with extreme keratometry or axial length to ensure optimal visual outcome in these patients. Thank you very much.
Thank you, Professor Jagat for enlightening us on the intraop aberrometry. I think most people would not go in for this device because for every use you will have to pay a license to the company.
Actually it was benefit to us because here government was paying. Maybe on the private side you have to take from the patient. We take nothing from the patient. It was complementary for all the patients, whether it is a intraoperative biometry or this interferometry. It was complementary, so there was no problem for us. But now I realized, because I am also in the private setup with Grewala Institute, I realized that everything costs money. No. Now I am realizing the value of that each technique and each investigation, it cost money.
So for specific cases like post-RK, post-refractive surgery, complex cases, I think it is a boon. But I think for routine cases, if you have a good optical biometry.
Yeah, definitely I think not routine. It is selectively where I have used it for RK patients, not even PRK patient, only RK patient. And it is used for pediatric because they may not allow you to keratometry and even axial length, sometime younger children. So I have used there where you planned IOL implantation. That is not something that literature has shown that how many pediatric studies are there, but I have used in pediatric also. So it is to be selectively to be used, not in every case.